We with the time. 12:04, I think we should start.
Yeah.
Okay. All right. Okay, welcome everyone. Sound is on. The air conditioning is on. For those of you braving the cold in this room, thank you. And for those of you online, welcome. This is a new meeting that is going to be looking at community participation in Plural Health Systems. I'm Leslie London from the School of Public Health, and we are going to be taking you through some research that is trying to develop models for how we can include community participation in a plural health system. We have a collaboration with researchers in India and Brazil, where we are looking at similarities and differences across different fields. The Brazilian context is one where they have a lot of participation from private providers in the public health system called the SUS. And the SUS, as many of you will know, is a very successful initiative that has brought down infant mortality and has a very positive impact on health. And they have a very mixed system where they have public and private providers in one system delivering care, and we call that plural health systems. India, on the other hand, has nothing of the sort. They have a private system and they have a public system, and they don't meet. South Africa is somewhat in between because, as you know, we are developing a national health insurance. It's unclear when it's actually going to happen, but there's a lot of talk, so we are moving in that direction. And under the national health insurance, we will have private providers contracted in or arranged to provide care on the public platform. So we have a sort of in-between system. So this session today is really sharing some of the research that has been conducted, and we are going to ask you all to participate in finding solutions, because we don't in South Africa have any real way of anticipating how the NHI is going to implement community participation. We have systems in the public sector with many problems. We have no systems in the private sector. So if you bring them together, how's it going to work? How's the community going to get a voice? So we're going to have some presentations about the research that's been done. We're going to have a response from a community participant. Then we are going to ask you to look at what is being proposed as a solution for this problem, and then give us feedback. So you're all going to do a bit of work. And then right at the end, Tracy Naledi is going to close. So I'm going to introduce the participants who will then go one after the other. Haricharan is going to start talking about some of the research done. Then Therese Boulle, who's based in Ruya in the Eastern Cape, will talk about some work done with health committees. Then Natasha Ruya, who's a PhD student, will talk about some of the work done thinking around solutions. And then Christine Johnson from Manenberg Health Forum will give a community response. So each of you will just follow. I will stand in the background. Over to you, Hannah.
Okay, thank you. So I will start talking about some of the first steps in this project, and I'm just getting instructions on how to work the computer. And that is some key findings from some scoping reviews we did and some policy mapping looking at which space participation has in the national health insurance. So when we started this project, we did 3 scoping reviews. One looked at what is a plural health system, what characterizes it, how is community participation organized in plural health system, and how does contracting with input from communities work. I'm not going to say much about the contracting because we haven't really gotten there in national health insurance, and I'm going to use the findings for the scoping reviews to look at the space of participation in the national health insurance. So from the scoping review of plural health system, really, as Leslie said, a plural health system is where there is lots of coordination between private and public, and it's sort of a unified health system. We just had a meeting, some of us, with a private provider that we hopefully will work with, who talked about how at the ground level, people use public and private, but there is no coordination, and because of that, there's a struggle to get data sharing, results, there's a waste of time, overuse of medicines, etc. So it's sort of like we are at a stage where there is a lot of pluralism at the ground level, but that the system has no coordination mechanisms. So in the plural health system, we have coordination. What we have currently is more of a mixed health system with two different systems without enough coordination. The scoping review of community participation found, not so much to our surprise, that very few countries have mechanisms for participation in plural health system. There were three exceptions, and those are Brazil, Thailand, and Colombia. We sort of mapped the spaces for participation, and we found the following spaces. So at national level, in Brazil and Thailand, we have something called health conferences. So that's where community members and policymakers and health professionals get together to discuss health service delivery, policies, benefit packages, and the like. Those conferences also exist at provincial and regional and local level, and it's sort of a tier system where issues are taken through the system to finally be addressed at national level. And then after that, there's a committee that look at all the suggestions and decide what should happen and communicate to the public which processes and suggestions are being taken forward and which are not, and why. In Thailand, we found that the main medical scheme, Thailand has 3. The main medical scheme covers 75% of the population, and they have a board with 5 civil society organization representatives. The same as the structure that implements healthcare, they also have 5 CSO. At district level, we found that Brazil have health councils, and they actually also have in some municipalities participation at private facility. In Colombia, we found something called user committees. User committees are committees linked to medical schemes. So Colombia has a different model for universal healthcare where there are many medical schemes and each of them are supposed to have a user committee. So some key findings. We also looked specifically at social accountability, which is an aspect of health governance. And we found that many of these structures have an accountability feature. In addition, we found that in Thailand, we had at national level an independent accountability structure with community input. And at local level, we also had community-based complaints units, which were managed by local CSOs. So key lessons. Generally in the literature, the conferences were sort of concerned with high-level influence, and they were seen as quite effective. The same with representation on the medical aid schemes and with the Brazilian Council. The user committees were not seen as effective. There was only one article actually dealing with the user committees, and they identified lack of support as the main reason why these committees were not effective. So that's sort of the key findings from these articles. So then to the national health insurance. Do we find similar spaces that we find internationally in our national health insurance? So I pulled out sort of 3 central committees from the legislation. The first of them is the board, and as many of you will know, appointment to the board is done by the National Health Minister. And it's mostly people that have some kind of technical skill in, for instance, law, in public health, in finance. And there are no user representatives. There are two other relevant committees. One is the Benefit Advisory Committee, which is obviously the committee that's going to decide what's going to be covered by the national health insurance. And here we have space for a person with knowledge of patients' rights, but it doesn't say that that person should necessarily represent patients. On the stakeholder committee, we have civil society organizations and patient advocacy groups represented, which I suppose from our perspective is good. The issue is that we don't know what the stakeholder committee is actually going to do. At local level, most of you will know that the NHI is going to be managed by what's called a contracting unit. And they are composed by district hospital, clinics, ward-based outreach team, and private providers. Again, no representation by communities. We do believe that this could be an ideal space for participation based on some of the duties of these units, which is to identify health needs, identify providers, manage contracts, and resolve complaints. Some of the issues that health committees are also supposed to be dealing with according to the ideal clinic. The one place for participation in the National Health Insurance actually doesn't come in the National Health Insurance Act, but in an amendment to the National Health Act that will come into place with the National Health Insurance. And that is that the Director General, the District Health Management Office, and the District Health Council must, and I quote, promote community participation in the planning, provision, and evaluation of health services in a health district. So this is quite a broad definition of participation, which is very much in line with the human rights and the primary healthcare approach to participation. The problem for me is that as it is very broad, it is also not very specific. It doesn't say anything about how, who, what mechanisms. It is, to use the word of a community participant in some community dialogues said about the NHI, it's a beautiful elephant, but we don't know what's inside it. And it's the same with community participation in the National Health Insurance. It's a beautiful elephant, that quote, but we don't know exactly how it's going to play out. So to sum up, there's very limited opportunity for participation in the National Health Act, National Health Insurance, and it's uncertain how the NHA obligation is going to be carried out. We may end up with a system where we will continue to have health committees and health facility boards at public facility level, but we will not have anything at private facility level. And that situation is what we are trying to see. What do we do with this scenario? So that's it for me. Thank you.
Hi, it's me next. I'm Therese, and I'm sitting next to Andiswa, and we've been working together here in Gqeberha, and yeah, so I'm presenting now on the findings from some research that we've done in Nelson Mandela Bay and in Cape Town on working with health committees. This research was took place in May and June last year, and this here is a photo from the community dialogue that we held in Gqeberha, where we gave feedback on the research. Okay, so what was our aim? Our aim was to map the health committees in both Nelson Mandela Bay and the sub-districts of Klipfontein and Khayelitsha, to understand their levels of functioning and the roles they were playing, and then to explore further what health committee members understood about the NHI and how much they may have engaged with the NHI. So we used a mixed method approach, both quantitative and qualitative. We conducted surveys, and as you can see, both the Western Cape and Eastern Cape, we had 279 health committee members complete the surveys, and they were all included in focus group discussions. So we had 28 in all, and we also took field notes wherever we went and included that into our reports. We looked at roles and practice of the health committees. We had done some research from 2012 to 2015 previously, but particularly here in the Eastern Cape, we weren't up to date with what was happening. So we looked at a variety of variables, and I've just pulled out a few here, and kind of tried to show you some of the things where there were discrepancies. So, for example, the health committees will say that they're very involved in governance and monitoring of service delivery, but actually they have very little authority to enforce any kind of accountability. They do awareness and outreach, and this seemed to indicate strong engagement, but actually they say their input is often not very valued, particularly by managers in the facilities and often by the district too, or mostly by the district too. They address health issues in the community. You know, these committee members are amazing. They get sidelined when they go to the shops. They're in their streets. People come and approach them and ask for support in terms of the health issues that they're facing, but it's often in this informal way. And they've said that almost all of the committees are involved in complaints management, but the application is very varied. And often they've said that Facebook was the most effective way of getting some results. So we're looking at the challenges and enabling factors, and here community participation in health governance is shaped by both challenges and enabling factors. And so on the left, you can see the major barriers that the committees face, including a lack of training, and particularly as you hear around the NHI. There are unclear roles and there's weak collaboration with the facilities. And as regards resources, they're often very under-resourced, particularly in terms of space and laptops, for example. There are strong enabling factors, however. Committees are eager for training. They want to build up their skills, their knowledge, and their capacity. They really are trusted by the community, and they serve as key health advocates. They're also very active in monitoring the service delivery, and what we felt is that the NHI could create structured roles and governance for these committees or for committees in the future. So moving on into more about the NHI, you know, our surveys looked at the NHI, and then in our focus groups, we also asked a lot more. So whilst the surveys showed actually that there was some awareness and knowledge, some had discussed, some said they had received some training. When we talked about it in the focus group discussions, it was clear that the knowledge was pretty poor, and that actually it seemed to center around community members who were kind of more well connected. And yeah, they were the ones who had some training or some discussion or some knowledge of the NHI. The general lack of discussion means that most participants lack exposure to NHI information. And we had one site in the Eastern Cape where members were part of a pilot, and they too felt that they lacked knowledge. In fact, they'd had a 4-hour session of induction from 10 10 till 2, and they said they had lunch in between. So actually it was very little time that they'd spent on the NHI. So as regards what their perceptions were of influencing the NHI, well, as you can see from this quote, it says, if the NHI recognizes us, we can be part of real change. But health committees really are unsure of their ability to influence the NHI. Many of the committee members with whom we engaged said they didn't use and make use of private practitioners. They were fairly apprehensive of them and particularly of trying to engage with them. So as you can see here on these graphs, you can see the Eastern Cape. It lags behind in terms of its understanding, knowledge, influence, because yeah, the Eastern Cape just has so much less in that regard. But this picture is pretty hopeful because this was from our dialogue where our committee members were looking at what can you do to influence or to be part of the NHI, and bringing the committee members together from the whole metro was really helpful because people started firing ideas and suggestions and actually building some confidence that maybe there was an opportunity for them. So in conclusion, health committees have limited awareness and engagement with the NHI, and particularly in feeling that they can influence the private sector accountability. While some feel they can impact service delivery, many remain uncertain. And the focus groups highlighted the need for more information. So there is a need for targeted training on the NHI and the private sector engagement. There's a need for us to develop clear and accessible materials to improve health committee understanding of the NHI and their potential role in it. And we need to facilitate more dialogues between health committees, between the Department of Health, government, and private providers to strengthen collaboration. And then my last slide is the one that Hannah alludes to. Thank you.
Good afternoon, everyone. I am Natasha Ruya, and I'll be sharing with you our suggested complex intervention, which is more or less trying to bridge the public and the private healthcare through community engagement. So just to share with you a brief background on how we came to be, or the process behind the co-creation. After we conducted the research, as my colleague highlighted, we went on to do 3 community dialogues in Western Cape, that is Haricharan and Klipfontein, and in Mandela Bay in the Eastern Cape, where we tried to share the research findings and explore some of the strategies that we could adopt and suggest as a potential intervention. We also went on to have a series of engagement with our community coordinators, who are health committee members, to try and find what can we say is the right, the ideal intervention that we could introduce as part of that. So through all that engagement, we identified that there is a need for structured engagement with the private healthcare facilities. And currently we are in the process of engaging with private providers to share with them our suggested intervention so that we could hear from them their feedback as a way of shaping the intervention. So what we are currently proposing is have user committees at private facilities. As I highlighted earlier on, currently we have health committees in the public facilities, which is a platform and space for community participation. But that kind of space for community participation is not found in the private sector. So what the public health committee in the public sector health committees have, they have a space where they can also meet, which is the Sub-District Health Forum, and they can discuss and collaborate fully in that context. However, as the private sector was still in an isolated space, we are suggesting that if we have the user committees in the private facilities, they could be part of the Sub-District Health Forum, which they can also be part of that discussion of discussing health in the broader context. In collaborating with other health committees in Cape Town. So looking at what the user committee will be looking like, just to give a clarification, the user committees that we are currently suggesting, they are different from the user committees in Colombia, which were spoken of by Hannah. They are mostly the patients who are utilizing the private facilities at a facility. So those are the ones that we are targeting as to make up part of the user committees. And the roles that we are suggesting, these are not the roles that we are suggesting, all of them, but those are some of the few that we'll be saying, we are suggesting that they will be partaking. And one of the being the bridge between the community and the facilities themselves, which is currently what the health committees in the public facilities are currently doing. And these roles, they have been taken from our understanding of what currently health committees are currently doing, as well as what the ideal clinic would be advocating for. So basically what these committees are doing, or what the user committee will be doing, it's mirroring what the health committees in public facilities will be actually doing. So what would the whole structure or the pilot structure look like? We are envisioning having 1 or 2 user committees in Klipfontein, Khayelitsha, as well as Mandela Bay. And through the session that will be having them, will have an intensive support system that is in form of trainings for both the health committees and the public facilities. As highlighted by Therese earlier on, we identified that health committees, they still need a lot of trainings in terms of how they engage with the facilities and how they conduct their roles and responsibilities, basically. So we believe that kind of ongoing training is important for them, as we will have on board the user committees. They'll also get that kind of training. At the same time, hand-holding, mentoring along the way as user committees is currently a new structure for them. And we believe that through the training and mentoring process, it will also be spaces where they can collaborate and exchange ideas or just general discussions with the experienced health committees that are there. So for us to have these structures, we factored in what are some of the strategies that we feel are important for this form of engagement. The first one, which we are currently doing, that is engaging with the private providers and just discuss with them their willingness to be part of the intervention if they would want us to come up with the user committees as aligned with their facilities. In case we do not find committees of private providers who are not that willing, we thought of a strategy of monitoring as an outside source. And by monitoring as an outside source, I can give you a context of health committees in Khayelitsha. We have 2 types of health committees in Khayelitsha. The first one, which is the appointed committee by the ABC, that are aligned to all the clinics in Khayelitsha. And we also have the independent health committee, which are mostly make up the forums. So that is the same strategy that would want to adopt in case we find private providers who are not willing to be part of the intervention. So just to emphasize, we are in the process of currently engaging these private providers. But one of the challenges we spoke about, or we are also noting during this interaction, is how do we balance the business interest and the patient advocacy, which is also something that we believe can be assisted in the context of the NHI if it then is implemented. The Sub-District Health Forum can be a platform which can interact with the District Health Council or the contracting units for primary health care. So we are also refining this model if it's going to work by currently engaging with different stakeholders. And today, that is also part of the essence why we feel we would require your assistance in terms of assessing if this is a model that can work or not. So we are not yet going in our breakout rooms, but just to just have questions of reflections, like what are your thoughts in terms of this proposed intervention? Do you think there are any suggestions, or are there some things or we haven't considered that might strengthen this model? So with that, I thank you, and I call on Christine to share in the community perspective.
So the question for us as communities are, will this model work for us? Yes, but we do need the support of the university, we need the support of the Department of Health, and we need the support of the private provider. As has been proven by our meeting this morning with the private provider. Well, they be willing to give us access to the this.
Okay, so I wonder if you put the question up.
Yeah.
So thanks all of the speakers. So basically we've mapped out the problem. We've mapped out a way of trying to find some solutions. And we had thought this room would be full of people who would break into groups, but essentially you're one group. So these questions are for you. And to raise, you're going to facilitate the discussion online. So we're going to
Mute them.
We're going to mute them.
And mute ourselves.
Yeah, so we're going to mute, so you can have the discussion online with your colleagues, but we will mute you. Yeah. Yeah. Okay, just reduce our volume. And about the presentations, Therese and Andiswa can deal with them online and we can deal with them here. Okay. So, over to you all.
Radio guys, it's us now. Can you unmute so that we can have a discussion amongst ourselves? Okay, so the first question is, what are your thoughts on this intervention model? It's, as you can hear, it actually has not been an easy process to kind of think about how do we get to an intervention, because this is what we said we would try and do to promote and to enhance community participation in a plural health system. So we'd love to hear what your ideas and views are. Can you take notes? And then will you report back? Yes. Okay, perfect. So Andiswa will take notes and will report back. So yeah, let's chat. Maria.
Hi, everyone. Thanks so much for the presentation. It was really interesting and all the hard work that you've put in and some really interesting insights. I think what stood out for me about the proposed intervention, I'm currently based in the Western Cape in the Cape Town District Office. And so what stood out for me about what the team is proposing was it seemed like there was going to be separate user or committees for the public facilities and for the private facilities in a specific geographic area, if I understand the proposed model. And I wondered whether that might be counterproductive to the overall goals of the NHI in terms of bridging inequality. So one would want systems of accountability that apply similar standards to any provider that has fulfilled the criteria to be an NHI contracted provider. So I just wondered would it actually be good to have two kinds of teams advocating for communities based on whether it's a public or a private provider, or should there be some sort of unified voice? That's just something that jumped out at me, but happy to hear what other people think about that. Thanks.
Oh, thanks, Maria. Yes, in fact, we had considered that because we thought that there needed to be a space in which the two came together. So here in the Eastern Cape, I'm not sure if it's the same there, we have a district health forum where all the sub-districts and their representatives from the clinic committees come together. And we considered that that might be a forum that we could utilize for both public and private as a way of kind of bringing that together. But a very valid point. Thank you. You're welcome to just jump in. Oh, Sherbet, sorry. Sorry, that was my phone. You're welcome to just jump in or raise your hand if you've got something, if you'd like to contribute.
Hello, everyone.
Hi, Goodman.
Thank you very much. My name is Goodman Makanda. I'm based in the Cape Town, Western Cape. Firstly, I will say congratulations. You guys did well on this because it's not easy to deal with these clinic committees and put them in one place and all of that because lack of funding and transportation and all of that. I'm working for TB Proof as a TB advocate and a research assistant, also affiliated with UCT at KTU, Knowledge Translate Unit. But I'm just now thinking, how can we, anything that we have maybe considered that to strengthening this? So as I'm saying, I'm also working with clinic committees, and it's not an easy job to do. For me, the accountability for TB around that. But what I've been learning along the road, all of these things to make sure the community at large, it can taking accountability when it comes to health or this, what we call NHI, even in private, in public. I've been like trying to engage even other stakeholders, not only focusing on the clinic committees. And you must remember, most of these clinic committees, they are not every day in the healthcare facility, but the commuters itself, they are using of these public facilities. So even to engage here in Cape Town, Sanco, CPF, those people to have a knowledge and to hear their knowledge around when it comes to NHI, do they know about it? Because they are the people, I think they are most of the time visible, even the councillors. Yesterday I've been speaking with a person that controlling the councillors in our community, to say, I need them because they are the community leaders. We should be checking on that to say what kind of community leaders that we can also use to make sure this accountability around NHI, around health at large, they can contribute in. Even the traditional healers, mostly, or all of them, I can count few, the churches. So that is the people that we forget, and we should be bringing in to this strengthening health when it comes to our communities, not only targeting those being initiated by the MEC. And the confusion is still there. When these people applying this, they thought they will be getting some jobs on something else. But when it's been explained, no, this is a voluntary, you find out in Kailicha or maybe each clinic, only one person that is active as a clinic committee. So we need to combine all the stakeholders, put it in the one room and hear their views of what they think. So it can be easy even to say, let's work together towards this so we can accomplish all of what we are looking for and the community that is, they are also looking for. I don't know if I make sense. Thank you very much.
Thank you. Yes, you do. You make a lot of sense. So your suggestion is to expand the number of stakeholders and the variety of stakeholders so that we include very many more members of the community. Thank you. Anyone else? Any of the 3 questions will be gladly appreciated. Okay, we've got one in the chat. I would suggest specific structure for topics discussed and feedback mechanisms for committee meetings, as in my experience in the Eastern Cape, there were just a few people attending, very inconsistent attendance, and mostly listening to staff speak. So a report would help share information and work of the committees. Yes. Yeah, you're right. We really need proper feedback mechanisms, because I think we're often in the situation where we actually have meetings quite often, but they go nowhere. The issues, not even the facility managers can often take up. So yeah, we need to escalate those issues. And yeah, thank you. Do you want to add more to it, Farzaneh?
Sure. I think in terms of topics discussed, it's sometimes always just complaints. So actually having a really good structure for what does get discussed, specific highlights, and then some sort of report that can be shared with people. So you can actually see how the committee is working if you're an outside person, or it gets reported in a newspaper or something like that. Here are some highlights from the clinic committees. That would be wonderful.
Yeah.
Thanks.
Thank you. Thank you. Yeah, nice idea. Other ideas, other suggestions? Maria, you want to? Maria, you back again? Yeah.
I can go after the other hand.
I can't see who the other hand is. Sorry. Oh, yeah. I just see Kani. I can't see the whole word. Sorry. Come in.
Hi, good afternoon,
Kaniz,
everyone.
yeah.
I'm quite new to this group. I'm Kaniz. I'm going to be starting as a public health registrar this year. Just joining a bit prematurely to the meetings.
Welcome.
I just thought for the private committees, a lot of the user issues may come from or be determined by medical aid issues, and not necessarily just the provider in terms of the facilities, the private facilities. So perhaps incorporating some sort of engagement or representative from that aspect as well.
Yes, good suggestion. Yes. Very much so, because we've seen their reluctance and opposition. So you're right. It would be helpful for us to engage them. Maria.
Yeah, I just wanted to comment on something else that came up in the presentation, which was that complaints or comments or feedback from patients or their families that were perhaps actually voiced on maybe social media or Facebook and other such platforms were often, promptly addressed or resulted in some or other response from the health provider. And I think perhaps in your proposed model, there might be a greater role for the use of technology platforms, whether it's social media or whether it's some or other rating website or some website where you could rate a healthcare provider or some other format, just considering that actually both public sector providers as well as private sector providers are very conscious of their brand online, and more, even more so under an NHI type of a system. So those kind of platforms would be really helpful to continue to use or to use more strategically. And then, of course, in communities where people might not have access to internet or smartphones or such things, maybe then the health committee could be the person that posts on their behalf or somehow uses that platform where people maybe can't do it for themselves. Over.
Thank you. Sorry, my battery is running low. I did. There we go. Yeah. Yes. Clearly, clearly the social media worked very well. But we definitely need to consider that, and maybe something that's accessible for people in that. Using those facilities, so it isn't necessarily start off as that broad sweeping out there telling the world how bad something is. It starts smaller before it goes into the public domain. Yeah. Okay, because that might be more acceptable. Certainly the Department of Health does not like it when people complain on social media. Not here anyway, in the Eastern Cape. Hannah.
Afternoon, everyone. I'm sorry, I joined a bit late, so I don't know if this question came up already. But it's partly related to one of the comments that one of the other that was given about how people join the health committees looking for jobs. And I just want to know what I know people are supposed to volunteer out of the kindness of their hearts to uplift their own communities. But how realistic that is in the current economic climate where people are really struggling, and we expect them to do this work, which is quite time intensive. What sort of remuneration or incentives or salaries should we be paying in this context?
So thanks, Hannah. In the Eastern Cape, our committees get 500 Rand a quarter, and I mean, it's really, really woeful. It's supposed to support them in terms of their cell phones and in terms of transport. Now, most of them don't require the transport, but their energy and their effort is incredible. So, I think we all have our views on that, but I definitely feel that they deserve a lot more, and certainly ward committees get paid more, and I don't see why we should expect clinic committee members to volunteer. Someone else had their hand up and they just pulled it down. Do you want to speak?
Yes, it's Suzuno. My hand is still up.
Oh, sorry, I can't see it here.
It's okay. Please. No problem. Yeah. Thank you. Yeah, so I also joined a bit late. So you had a slide, I think, as I was joining, where you spoke about the members of the clinic committees feeling that the clinics didn't value their input. So I didn't hear more around in terms of the intervention and getting that feedback to actually work, given how the committee members are actually seen as being advocates for the health of the communities. So how about strengthening that part so that this input is taken seriously and that they actually act on it, because it's the voice of the communities. So if you could say a little bit about that, and maybe that's something that you can look at in terms of strengthening in the model. Thank you. Over.
Thank you. So yes, I think working with the staff is definitely part of what we need to consider and do. Certainly here, the clinic committee members will say that they don't feel that they're valued, but the real reason for them not feeling valued is because nothing comes of their reports of where the problems or where they lie. So it feels as though they're talking into a vacuum, and I think that it's that often makes them feel that they're not properly valued. So it's a tricky issue because staff also often don't have the remedies or don't have the resources. And yeah, we certainly here in Nelson Mandela Bay, there are plenty of challenges in that regard. So, but I agree with you. It's a nice idea. Strengthen their input so that it gets heard. Make sure that their voices are heard and that they feel valued. Anyone else? I'm curious that we're going on for so long. We're supposed to have a 10-minute discussion, and then we were supposed to be back to feedback. So yeah, Ruth.
Hi, yes, Ruth Cornick from the Knowledge Translation Unit. My question, sorry if I've missed this, but
no problem.
I'm curious about whether you've taken these questions to community and to the clinic committee. So actually getting their input on the best methods to be engaging with people. So it's more kind of understanding their input into your methodology.
So that is, Ruth, it's really part of we're supposed to be doing that. It's supposed to be like a co-creation. So right now we're at the point where where we've just finished our research and we've taken it back, and now we're supposed to be co-creating. And these are very much, the Western Cape has got community coordinators with whom they work. We don't have such things here in the Eastern Cape. So already they've started looking at what can we do with the smallish coordinator cohort, but we're going to have to do it with like our district health forum and start to co-create ideas, because yes, you're right. There's no point us coming with ideas and then they fall flat. So thank you. Yeah. Anyone else? Okay, here we go. Okay, no, that was about leaving the meeting. Anyone else? But thank you. I feel sure that we were supposed to be going back. Anyone else want anything else to say while I send them a message and find out?
Is there anything that we haven't considered in what you've seen today?
What about South Africans in the diaspora?
I just wanted to ask, has it been decided in terms of the makeup of the facilities that this would service? For example, the primary GP level, the secondary hospital, the bigger private hospitals, just to ensure that there's adequate representation of all the levels of users.
Yeah, so at the moment we're trying to work with the GPs at this level, but that's where we're at the moment. But we definitely, I think we're going to have to also think about like talking with some hospital boards to find out where they're at in terms of this. But in terms of the NHI and in terms of our community participation, because we have the hospital boards in the public sector. So yeah. Okay, it looks like we're back. Thanks, Kaniz. Are we back, guys?
But yeah, no, that's a good suggestion. I suppose to some extent we have a sub-district that coordinates. That, but it could also be working with the district health coverage. Yeah.
So to those who are online, I hope you can hear me now.
Yes.
Yeah. So we've had a long, a very fruitful discussion about how to link participation structures in the private sector to legal authority to the authority of the MEC, but at the same time have a credible process for how they're selected. And even though the NHI is not in place, we need to work towards that to anticipate. I don't know, Therese, if you can just summarize in a couple of words what was said online to share with us. Oops, you're muted. You're muted, Therese. You're muted.
Okay.
I can do that for you as I was taking notes. The main, I would say the main point was, what is the intervention? How is the intervention going to include the public, right? Maria Jose wanted to know how the separate committees, like in the private and public, as proposed by the intervention, how that would be a prudent solution, like the separation of it, of these systems. Wouldn't it be more useful to have a unified voice? And Goodman Makanda from TB Proof suggested that the voluntary nature of clinic committees is a problem in itself, in that people aren't getting what they deserve, and that many stakeholders are not included or aware of what's happening in the health system. But
Don't worry, you don't need to. You just need to, yeah.
Another member of our community stated that the reports that clinic committees come up with it would be prudent for them to be publicized, so that the community has more awareness of what is happening in their facilities. Another member stated that private health committees would need to be inclusive of medical aids, as they would also be a huge factor to consider in an intervention. Complaints on social media would need to be something that might also be included in the intervention, as our research states that this has been more effective in getting these complaints dealt with. Maybe a website or a social media platform would be a possible inclusion in the intervention. And how realistic would it be for people to be expected to volunteer in this committee, in this economy, as we see that clinic committees are faced with this reality? And also, the intervention would need to address the feelings of clinic committee members who have stated that they do not feel valued. Also, what are clinic committees, what are their views on the methodology of the report of our research, and how can that be included in our intervention? And lastly, what about hospital boards and other systems of that nature? How can they be included? Thank you.
Okay, thanks very much, Therese and Yusfa, and everyone online for what was obviously a very helpful discussion. We're going to try and write up short notes, and when this is available, it is being recorded. It will be available to everyone. I'm going to hand over to Tracy just to say a few words, just to close us and send us on our way.
Thanks. Thank you very much for really interesting and thought-provoking conversations. The first thing I want to say, I just want to congratulate you for thinking about this at this time, because even though you made the comment around it's a beautiful elephant, but we don't know what's inside. That's the nature of policy making, that you do an act and then you do regulations that fill in the bits inside. So there's, and I think we also need to change this narrative that there's something wrong with how this policy is emerging. It's the nature of the beast. That's how it works. The regulations will be the ones that will tell us what's inside the elephant. And I think this process will then inform that. And I really think you've got some really good ideas on the table. And as I said earlier on when we were discussing, I really would like us to keep going back to the fundamentals of the primary healthcare approach, particularly a geographic model, and think about who are the service providers. We've been talking about public, private, but civil society is right there as well. And I think with NHI, there's an opportunity for civil society to actually be a legitimate provider of services, not be a middleman. You know, an NGO can legitimately provide CBS, community-based services, and the NHI trust actually buys from them directly so that they're not the middleman working through the department. And that's the whole idea of a plural health system, different parties working together collaboratively. So I want us to actually think about the role of NGOs in this and think about how we can bring them into the fore in that. And the other thing I suggested is around where does this live? And I think we need to use the current governance mechanisms that we have at the moment, formally or informally, as a way of thinking about how we then bring those that govern the system to be on that. And we had a really wonderful conversation here that centers around accountability. Accountability to the community, who brings us into these spaces, how do we get our mandate from them, how do we respond back to them? Similarly, on the service providers side, how do we actually ensure that it is in their interest to listen to the community voices? How do you ensure that it's in their interest to implement those interventions? So I think some kind of accountability conversation around how we strengthen accountability might be also something useful. But very exciting work. I don't know what else to say, but like great work. Thank you for inviting me.
Thanks to everyone online. We're going to close. CPD, the book is in the room for those who need CPD. For those of you online, you will also be able to access CPD. Thanks very much for all the participants. Thanks, Professor. Thanks.
Thank you.
Thanks.
Bye.
Isabella, you might want to fill in the CPD book.
Thank you so much.
I wonder if we can have a chat.